So we've been talking about stuffy noses for decades. And on Vital Discourse this week, we're going to tackle septoplasty, a very misunderstood procedure. One of the main causes of nasal obstruction is the septal deviation. And in fact, about 40% of people in the U.S. Have a deviated septum. It's funny how that Venn diagram maps nicely with snoring. We'll get into that. A significant septal deviation is a common cause of nasal obstruction, and so septoplasties, which is a treatment for it, is also fairly common, coming in at about 260,000 procedures a year. And so it's still poorly understood. Why is it still poorly understood? We're going to get into that in this week's Vital Discourse. Dr. Lee, we do massive numbers of septoplasties per year. We're both use it as a means, one of the means for helping people figure out their sleep disordered breathing and their nasal congestion, whatnot, headaches. Why is a deviated septum so common? Why is 40% of the population have a fairly significant deviation to their septum?
Well, first, Dr. Ben, I must say, I love Venn diagrams. Don't you love Venn diagrams? You mentioned them in your opening, so I just wanted to get that out there. Little joke.
I do. I call them Venn diagrams.
Venn diagrams. So, to answer your question, to septal deviation, first of all, what's the nasal septum? Nasal septum is the wall between the two sides of your nose, right? So, classically, you should have equal airflow through both sides. If the septum is pushed to one side or pushed to the other side, it will limit your airflow. If it limits your airflow, a few different things can happen. Number one, it's uncomfortable because you can't breathe. Number two, when you're doing sports or engaging in any type of exercise, you become a mouth breather. Your oxygenation, the amount of oxygen in your system drops down. And it can cause other things because of its obstruction, like sinusitis issues and the like. So the other kind of part of this is, how is a deviated septum caused? So classically, there are two things that can cause a deviated septum earlier in life, as opposed to, for example, later in life, trauma, that type of thing. One is through the birth canal. So during birth, coming through the birth canal, the septum can actually be knocked off its little crest. It's supposed to sit on a little ridge. It can be knocked off its ridge as coming through the birth canal, and that can start a deviation of the septum. Second is just developmental. The facial skeleton is growing when we're young, and as it grows, there are different paths, growth plates, that will open and close at different times, and depending on the timing of that, the septum can end up on the other side of the midline or the other side of the middle. So it's very common to have some deviation. The question is that deviation clinically significant? In other words, is it causing a problem? Is it causing symptoms? And I explain that to patients all the time. Patients will come in and say, I have a deviated septum. My primary care physician told me that. I'm coming to you because I want it fixed. And I look, yeah, you have a deviated septum. There's no question. Are you having symptoms from it? Well, no, I breathe absolutely fine. Well, you breathe fine. You're having no symptoms. You have no sinusitis. We don't need to fix it. So that's kind of one of the myths, that just because your septum is deviated, that it has to be fixed.
Yeah, so you think that you're not breathing well through your nose. You suspect it might be a deviated septum. You've gone to your doc, urgent care, or your family practice doc. They're not really sure either. So you decide to go to a specialist. But you're afraid because your Uncle Jack had a similar procedure and was in terrible pain. Over the 30 minutes of this episode, what you're going to learn is that's not true anymore. It's a fairly short surgery with a fairly easy recovery. It's easy to diagnose as well. This is not your parents' septoplasty. Come learn with us, and let me take you through all that over the next 30 minutes. Don't miss it. I want to stop you there, though, Lee, and ask you a question. If it's been there your entire life, a lot of people don't register that it's a problem until the secondary problems start to occur, like sleep disordered breathing and snoring, sleep apnea, chronic sinusitis. And then they were unaware. I've had people sit in my in the chair there in my office, and when I ask them, do you breathe well through your nose, they say yes, while I watch them mouth breathe through the entire session, and then I find out that they snore, and then we find out that they have sleep apnea. So if it's been there your whole life, quite often people are unaware of the primary issue, nasal breathing, but the secondary issues that can come from chronic mouth breathing is what they come in for.
Yeah, I agree completely.
Two sides of the same coin.
You don't know what you don't know. So
Right.
if your whole life you breathed a specific way, you don't know that you could be breathing better. You don't know that breathing through your mouth the whole time isn't what you're supposed to do. So when things start building, right, when this obstruction over time causes thickening of the lining of the sinuses, thickening of the lining of the nose, starts causing sleep disordered breathing because now we have some muscular issues in the throat that might be collapsing the airway because of the nasal breathing, kind of the nasal breathing is initiating the effect. That's when we start seeking medical advice for it.
Yeah, so basically what you're saying, look, just because everybody might have a deviated septum doesn't mean that everybody needs surgery. That's the bottom line.
Absolutely.
So we kind of went over what is a deviated septum. What is septoplasty? What does that term mean even?
So septoplasty means changing the shape of the septum. Now, usually, obviously, we're trying to change the shape of the septum so it's straight, right? So we get equal airflow on both sides. There are other structures in the nose that might need to be addressed as well. So the septum deviates, and there might be another structure, for example, the turbinate, okay, where that will grow into the space created by that deviation. So you try and straighten that septum and it's going to bang into that turbinate. You need to make that turbinate smaller so that when it comes to the septum comes to the middle, you actually get airflow on the other side. So it's kind of a robbing Peter to pay Paul principle, so to speak. But
a zero-sum game. Yeah.
So the bottom line is what we're doing in septoplasty, we're trying to get the septum straight so there's equal airflow on both sides. Sometimes it can be more difficult or less difficult depending on which part of the septum is deviated. So the back part of the septum is bony. The front part of the septum, excuse me, the front part of the septum is cartilage. Well, bony septal deviations, pretty easy to fix. You kind of rock out the thin piece of bone and it's fixed. Front part of the septum, the cartilage can be a little bit more difficult because there could be a bend that's more of a permanent bend. There are bends in the cartilage that are just a bend under pressure that when you release the pressure, boom, it snaps back to where it's supposed to be. And then there are bends that are kind of scarred in or more permanent bends that you actually need to work on that bend or change that structure in order to get it to stay straight.
So you come in, a patient comes in, they have nasal obstruction, they have a deviated septum. Is there a way to treat that without doing surgery?
Well, maybe. And the reason I say maybe is that you can't treat a deviated septum without straightening it. So I always tell patients, Flonase has never straightened a nasal septum. However, what you're dealing with is an airway that's narrow. The airway is narrowed by the deviation. If there's any level of swelling of that narrow airway, you're going to potentially get more symptoms. So you can have someone that has no symptoms. They have just enough airway, even though their septum is deviated, but then on top of it, they get some allergy or they get some chronic sinusitis. And boom, now they're closed. So theoretically, you can treat that underlying medical condition with medication, things like steroid nasal sprays, decongestants, allergy immunotherapy to treat it, and you may get them back to where they are feeling well and not have to go about straightening the nasal septum.
So really, there's no way to straighten the septum medically, but you can effectively sometimes get them where they need to be breathing-wise by giving them different types of medication. That's what I'm hearing, right?
Correct. Different types of medication, or for example, allergy immunotherapy, which is not actually medication.
So once if that isn't adequate, or if it doesn't get us where we want to be, and we do the surgery, what does that look like? Like what does a septoplasty in 2026 entail? Where are you doing it? How long does it take? What's the post-op like? Remember, this has a bad reputation. Septoplasty has a bad reputation in patients because the Uncle Joe had it 20 years ago, and they were miserable. They were in tons of pain, and then they had to pull these big splints out, and everyone was, mass hysteria. What's it like now?
So first, this ain't your parents' septoplasty, right? So the methods, the techniques that we use now, classically, there's still some people that use the old techniques, but classically, the newer techniques that we use don't require hospital stays, don't require surgery in the hospital. And in fact, I do pretty much all of my septoplasties in the office. It literally, I can do a septoplasty in 5 to 10 minutes, depending on the type of septoplasty. There are some that are more complicated that take a little bit longer, but they pretty much can all be done in an office setting. Now, some people can even tolerate a septoplasty with just local anesthesia. That's kind of few and far between, but it can be done. So what are you looking at? What you're looking at is septoplasty alone. Like I said, maybe a 10-minute procedure. If we're combining it with other things like shrinking the turbinates or doing some sinus work, maybe a 20, 30-minute procedure max. It can be done in the office. Many times it's also done in surgery centers. The requirement of packing in the nose is pretty much gone with the techniques that we use. I know I rarely ever use packing in the nose after a septoplasty. The only time I usually use it is if someone has some kind of underlying bleeding disorder or that type of thing, where I think there might be a bleeding issue afterwards, but that's very, very rare. So we're not using packing in the nose. So those big plugs that people had in their nose, that's gone. The 6 feet of gauze, that's gone.
So what that means is there's less pain. That's what used to cause the pain, was all the packing and the splints.
Generally speaking, septoplasty is not a painful procedure. Now, certainly after septoplasty, if you do that to your nose, it's going to smart. But generally speaking, it is not a painful procedure. You could expect 24 hours of some bloody nasal discharge. You can expect some swelling because of the procedure over a week or two afterwards. But usually by week 3 afterwards, patients are doing great. They're breathing beautifully. I tell patients 48 hours, hang out, don't do a whole lot of anything. After 48 hours, go back to normal activity, nothing overly strenuous the first week, and we're good.
So I have a very similar experience with recuperation. I don't pack the nose or put splints in, so there's not a lot of pain, just like Dr. Lee. Takes me about 10 minutes to do as well. And then afterwards, what I tell folks is you're going to drip for about 24, sometimes 36 hours, so you'll have a pad under your nose. We teach them how to clean it. We teach them to keep their head elevated and put a cool compress over it for the first few days. But then after that, they start to slowly open up. At days 4, 5, and 6, they're starting to get air through their nose, and they're feeling pretty normal. So I can clearly remember back in the 90s putting those big old splints in and packing the nose and doing it the old way, where you're miserable for maybe 1 to 2, even 3 weeks afterwards. And I can tell you, this is a very different ballgame. Now, we just both sort of on camera said that it's a 10-minute surgery, essentially. Is that always the case? And does that mean it's simple?
Yes, that's a great question. So it's only simple, I guess, in the right hands. It might be relatively simple for you or for me because we've done thousands of these and we're facial plastic surgery trained. And I would say that the anatomy in the head and neck, and especially in the nose and the nasal cavity and the sinuses, is incredibly complex. And when you're dealing with the nasal septum is a structural support for the remainder of the nose. So you have to understand that anything that you do can change the structure and the support for the remainder of the nose. And so if you don't understand that anatomy completely, you're going to have a very, very difficult time getting a septum completely straight the way it needs to be to get equal airflow on both sides, especially, as we said, when you're getting more to the front part of the nose. So yes, it can be a very simple procedure if you really know what you're doing.
That's a great point, Lee. One other point is this. The gray hair means something. I can tell you that in the beginning of my career, I was not as good at doing a septoplasty as I am now. Why? Well, it's very hard to learn. Anybody who has ever watched a septoplasty has not seen a septoplasty. You're trying to look over someone's shoulder and down a hole. With the advent of the endoscopic septoplasty, that's changed a little bit. But trying to understand what they're doing by they move out of the way, you look inside and see, and then they go back to working. The process for learning, the learning curve on septoplasty is actually longer than you would think for a surgery of its complexity. A lot of surgeons take an hour, hour and a half even to do a septoplasty. So when we're telling you that it's 10 minutes, we're not rushing. It's a direct result of the amount of time and effort that we've put into it over 4 decades between us.
And I also think that the fact that we're both facial plastic surgery trained makes a really, really big difference. So there are things that I have changed in the way I do a septoplasty that the change was made because I tried something, understanding that if there was a subsequent change in either the shape of the nose or the support or whatnot, I could easily fix it right on the spot and recognize it. Whereas anyone that's not facial plastics trained would not feel comfortable doing that.
Lee, do you have people coming in not understanding that a septoplasty isn't a rhinoplasty? What's a rhinoplasty, and why are the two very different?
Absolutely. So I have people coming in thinking that I'm going to break their nose when I straighten their septum. That is not a requirement of a septoplasty at all. A rhinoplasty is changing the external shape of your nose, what your nose looks like on the outside. It's a cosmetic procedure. A septoplasty is simply straightening the septum inside the nose. Now, the septum comes all the way up and it attaches to the area that you can see. But generally speaking, the top part of the nose where the septum is attaching is not really something that affects your nasal airflow. And so we can work on the septum and get you breathing without any cosmetic change whatsoever. And the insurance companies know that. So you're not going to get a rhinoplasty, a cosmetic procedure, performed through insurance. It just ain't going to happen. There was a time, long, long time ago, previous generation, where you could actually do a rhinoplasty with the amount of money that you would get paid for a septoplasty. Those days are long, long gone.
Yeah, no doubt. And so with the septoplasty, do you get a change to the outside of your nose? Can you get a change to it?
Well, so I put that in 2 categories. Number 1 is, do we want to change? And number 2 is, do we not want to change? So I have patients that will come in where their septum is so severely deviated that the cartilaginous part of the septum, the front part of the septum, is pushed over like that. Bones look fine, but this is like this. And when I straighten the septum on the inside, wow, lo and behold, this comes back to the middle. That's a wanted change.
You also see that with the nostrils too. Sometimes the nostrils are asymmetric.
Pushed all the way over, exactly.
Yeah.
So those are wanted changes, and those are changes that we see as a consequence of our necessary procedure to get them breathing better. And there's the unwanted change, okay? So I see this a lot of times when we have a septal deviation, a cartilage deviation very, very forward in the nose, in the part of the cartilage that's actually holding up the tip of the nose or right behind the tip of the nose, what's called the supratip area. So if you have the cartilage that's at a C shape like this, and it's a spring effect, okay? When you have those spring effect cartilage deviations in the front part of the nose, that spring, the pressure of the spring is holding this part of the nose up. And if you release that spring, sometimes, boom, this part comes down. Now, you really need to know what you're doing when you see that, which is the reason there are so many revision septoplasties required out there. Dr. Ben and I'm sure, see probably equal amounts of patients that come in that had a previous septoplasty, but now we need to revise it. Why? Because they didn't even address the front part of the septum. Why? Because they were fearful that they would get that drop and they wouldn't know what to do about it. So you really need to know what you do. You really need someone who's facial plastic surgery trained doing your septoplasty when there's a deviation all the way in the front part of the nose.
And sometimes, Lee, you have a tension nose deformity where you are too projected at the supratip because of the anterior septal angle. And you want it to drop back just a little bit because you have slit-like nostrils, and you get 1 millimeter, just 1 millimeter of drop, which won't really perceive, and you'll get a slight relaxation and opening of that nostril, which decreases the Venturi effect, which decreases the collapse and increases the nasal airway. And so, but you got to do that in a very controlled fashion. You can overdo it, and you can develop cosmetic problems.
And you need to let the patient know beforehand that you're doing that, right? Mm-hmm. And so what Dr. Ben's talking about is there's an angle inside the nose. It's called the nasal valve, okay? And so you have the nasal septum like this, and you have the side wall of the nose like this. And there's an angle here, and the air flows through that angle. About 50% of your air flows through that angle. So when you have someone with a really tall nose, that angle is like this. And when you have someone with a shorter nose, the angle is more like this. Obviously, with the shorter nose, there's more airflow. So if you have someone like this, sometimes you want to create this effect by bringing this down, right, to open up that angle.
Hey, Dr. Lee, so we've talked about a lot here. We've covered a lot in a short period of time. Septoplasties like that, though. You got to know why you do it, when you suspect you have a deviated septum, how it's done, and how you recover from it. So for the people that don't know out there, but suspect that they have a deviated septum and might need to be seen, what should they be looking for that might give them a clue? Maybe my septum's deviated.
Certainly, if they have decreased airflow or decreased ability to breathe through one side of their nose, right? So if it's only happening on one side of your nose, there's likely going to be a deviated septum, okay? The other thing that people might see is when they're sleeping at night, they're uncomfortable when they're sleeping on one side, but they're not uncomfortable when they're sleeping on the other side. So what tends to happen is people, when they're sleeping at night, if they have a deviated septum, they'll tend to want to sleep on the side that's deviated. Why is that? The side that's deviated is already closed. When you sleep on that side, blood flows down to that side, and it gets more obstructed, but you don't notice the difference. The side that's up opens up and you can breathe beautifully. If you shift to the other side, now the bad side is up, the good side is down, but the good side gets congested because the blood flows down to that side and you can't breathe either side of your nose. So that's another really good indication that you might have a deviated septum.
So, Dr. Lee, they come in, they can't breathe well, you fix their septum, they breathe well. They always going to breathe well? Do you do anything else? What's the recurrence rate / success rate?
Well, like a good lawyer, my answer is it depends.
It depends.
Okay? And what does it depend on? It depends on a variety of factors. The first thing is, and we spoke about it when we did our allergy podcast, is that you can actually create a double-edged sword effect where you're improving nasal airflow, but if someone has allergy, you're now allowing more of what they're allergic to inside their nose. And so they can get some secondary nasal obstruction because of now the allergy effect causing swelling. So you might have to then treat allergy in order to improve that. Now, the other thing that we see is certainly if someone didn't completely fix the septum, right after, especially if someone's using packing in their nose, it might feel like, wow, I can breathe really beautifully. And then as the effect of the packing really opening the nose, squishing all the lining down and compressing it, as that goes away, all of a sudden they're feeling the effect of the septum not being completely open. Right. So
yeah, I see that a lot.
Yeah. So you end up seeing that a lot. So that can cause a revision that might end up be by another surgeon. So when you look at revision rates for septoplasty in the literature, it's really hard to follow because people talk about their own revision rates, right? So someone might say, oh, my revision rate is 1% or less than 1%. And that's a good revision rate. That's about my revision rate. But realistically speaking, it's probably a lot higher than that because
it's probably 30 to 40% nationwide.
Yeah, because they're not seeing the people that don't come back to them. They go to someone else.
Right. Yeah, exactly. It's like Garrison Keillor, everybody's above average.
Right.
All right. So how many revisions, percentage-wise, revisions, septoplasties do you think you do a year? Not your own, but people coming in.
Oh, I would say probably about 40% of my septoplasties are revisions of other people's work.
Absolutely same here. And I'm about 2% by the numbers, 2% my own revisions. Maybe some years, maybe it's 1%. It's early on this year, and I'm currently at 2%. So yeah, I mean, some of it's probably egress.
I'll tell you one thing I've found as time has gone on in my career.
Yeah.
Earlier in my career, I was doing a lot more primary septoplasties, meaning I'm seeing the patient for the first time.
Right.
And now in my career, I'm seeing an abundance of second opinions, third opinions, fourth opinions after people have had 1 surgery, 2 surgery, 3 surgeries, 4 surgeries.
Yeah.
And what I'm finding is that my revision rate has increased, not necessarily because I have to revise my revised septoplasty because I was already doing a revision of someone else's work, but I have to start working on things like the nasal valve, secondarily, the side wall of the nose.
So do you consider that a failure or just an extension? Well, it's a failure of correction of congestion, but not a failure of the surgery of septoplasty. You're finding additional problems that you then need to address, right?
Yeah, I think it's more a failure of recognition that there was more than one issue going on at that time.
Right.
And
absolutely
most of the time I will recognize it, or most of the time I will say this might be an issue and explain that. Sometimes I'm taken completely by surprise. It just happens.
Well, yeah, like for nasal valve, remember that's the outside of the nose getting too floppy. If there's no air going through the nose because you got a deviated septum, you don't see the dynamic collapse, so you're not really sure. Sometimes you can guess by the shape of the nose how narrow it is right here, the outside that corresponds to the internal nasal valve. But a lot of times, yeah, if there's no air going through, you miss it until you fix their septum, and now there's air going through. Oh, it's collapsing.
And fortunately, there are some really very minimally invasive procedures that can be done to address the nasal valve.
Yes, there is.
Sometimes it's harder than that. Sometimes you have to do a Ben Cilento procedure and do an open rhinoplasty approach. He's unbelievable at fixing those types of noses.
So I appreciate that. And that kind of leads us to, we're going to be talking about rhinoplasty in the next episode. Look, for septoplasty, plasty means to change. You're changing the septum. It helps with a deviated septum and all the things that causes. We've looked at all of that in a very short period of time, but comprehensively. It's about correcting structural barriers when they meaningfully affect quality of life. And that should be the way we do it for all surgeries. But for septoplasty, not every single septum needs to be fixed, and not every person that's asymptomatic truly is asymptomatic. So that's why you go see a specialist. Great show, Lee. I think that we're going to go move on next week to rhinoplasty, and it's going to dovetail nicely with our talk on septoplasty and dealing with the nasal septum. So join us for that, and hope you enjoyed this week's episode.